As Megan said, I'm Jay Kempton, the administrator for Advantage Health Plans Trust, and over here to my left is, I guess it would be your right, Maria Robles Meyers, which is legal counsel for Advantage Health Plans and also works very closely with the Kempton Group. Maria's actually been pretty in quite a bit of demand here lately. Here the last couple of years, she's been invited to speak really pretty much all over the state of Oklahoma, and last year was also invited to go to the Self-Insurance Institute of America and talk to the self-insured industry about the Affordable Care Act. So we're very excited to have her with us and her to be on our team. Just briefly going through the agenda this morning, we are going to talk about the Affordable Care Act and the fines, the penalties, hopefully how to keep everyone out of all of those. But we've kind of divided or organized this presentation into three main areas. One of them is the Affordable Care Act and the benefit changes that are required in under the ACA or Obamacare. Some of those changes have already been implemented. Some of them are still to come. We're going to go through those with you. Also, we're going to talk about the taxes, or sometimes they're interchangeably known as fees or penalties or assessable amounts. But they're taxes, they're penalties. And under taxes, that's going to be divided into three areas as well, because there really are three components to the taxes and in the reporting as well. But the taxes, we're going to break those down into the individual's responsibility. And when I say individual, I'm talking about every single tax-paying citizen of the United States. As you know, you all are probably sitting there wearing a banker's hat today, but you're also, being a citizen, there's going to be some responsibilities for us as individuals. We'll talk about that. The employer responsibility, obviously that is self-explanatory, but there are responsibilities with penalties attached for non-compliance at the employer level. We'll talk about that. Plan responsibility. Those are going to be things that you as an employer, the benefit plan that you all offer is going to have to be able to meet certain criteria. If it doesn't meet that certain criteria, there are different levels of penalties or fees that are associated with non-compliance, and we're going to talk about that. The final segment is reporting. I've been listening and learning about the Affordable Care Act now since 2010, and only recently has it started to gel into my mind. It's probably like a lot of things that people learn throughout their lives, that you hear different bits and pieces and you have a pretty good understanding of the components. But that at some point in the future, it starts to kind of form, the puzzle pieces start to fit together. We've talked about this. We don't know whether we're just becoming more, maybe we're just desensitized to the craziness. But for us, this organizational structure that we've got of this presentation does kind of fit, because the reporting segment is also broken into employer, individual, and plan responsibility. And I like to think of that as essentially proof. How do we prove or report to the federal government that as an individual, we are fulfilling our responsibility? As an employer, how do we prove that we're fulfilling our responsibility? And then also as a plan, how are we fulfilling our responsibility so we can avoid the taxes, the penalties, fees, etc. Okay, with that, Maria, for those of you all that know me or have been on these before, Maria, she's the brains behind the presentation. I give color commentary, and hopefully sometimes if she gets too lawyery on us, I'll translate. But Maria, with that, I'm going to let you take it from here.
Okay. Well, we are in 2014, 4 years down the road from where we started when the Obamacare law was passed in September of 2010. And 2014 was to be the year when everything was going to be fully in place. As we got closer and closer, some things changed and some things got delayed. And even as I speak today, I'm going to caution you that what I'm telling you today is what I know as of today. And some of these things may change. This year alone, the regulations that have come out since January have been incredulous, and some things that we thought were set in concrete suddenly aren't in concrete anymore. So keep in mind, this really is an evolving law. The people that are setting the regulations don't have all the answers yet. They literally are creating it as they go. With that being said, I want to kind of talk a little bit about the benefit changes, the ACA benefit changes in terms of what plans are required to do, and that's going to kind of fill in. Advantage Health Plans Trust has a fiscal year. It starts July 1, 2014. And as you guys all know, as employers, you're not filing your individual 5500s for your plans. You're not reporting to the government. It is all done by AHP as a single plan with one single report. And it is a reporting entity that has a July 1. So when you hear me talk about the benefit changes as it regards AHP, the things that are required to be implemented in 2014 for AHP are implemented at effective July 1 of 2014. With that being said, the first thing that I want to bring up to your attention is the concept of children. I'm still not convinced that a child goes to age 26, but according to the law it does. And children up to age 26 are allowed to stay on the parent's plan without any conditions. It doesn't matter if the individual is employed. It doesn't matter if the child is married. There's no relevance to any factors other than they classify and are deemed to be a child. AHP has had this in place. It's a non-grandfathered plan, and so this provision has been in place without restrictions for several years now. The second big thing that is changing in 2014 is the concept of the pre-existing condition limitation. Pre-existing condition limitations have been in place and have been restricted. The new PPACA rule basically says that you can't have any pre-existing condition limitations. For AHP, it goes into effect July 1 of 2014. And what this means is if someone is on the plan and they were subject to a pre-existing condition because they hadn't met their 12 or 18-month period, effective July 1, none of that will matter. And those conditions will just be eliminated. There will be no need to look at them.
They'll be covered. Yeah.
They'll be covered without any restrictions. That being said, the concept of creditable coverage, as some of you may be familiar with, were the certificates that people got information regarding what kind of coverage they had, so that if they had prior coverage, this was the portability under the Clinton administration. It was designed to say that if you had coverage, then when you moved into a new plan, you got credit for the prior coverage. So if you had continuous coverage and had never had any kind of gap, then you took into account the time period that they'd been covered and might not have any pre-existing condition when they went into this plan. That kind of creditable coverage reporting obviously is going to go away, as there is no pre-existing condition limitation to be imposed. This is going to kind of be phased out, for our plan. Because it's a fiscal year plan, it's a July 1. For other plans where people have been on a calendar year plan, this has gone on since January. But our reporting and some of the forms that we use to notify people will be modified to reflect this, and the lack of need for these creditable coverage certificates is obviously going to go away.
I was going to say, the certificate of creditable coverage when one person was going from one job to another was, this is kind of a similar concept, something that we're going to talk about here later on in the presentation, but that was acted as proof that you had coverage in place, and that coverage met the federal standard. And so if you went from one employer to the next, you provided that certificate or that proof, then that new employer plan would not hold you to any sort of pre-existing condition limitation. As Maria just said, that's going to go away, but it is going to be replaced by another concept of a type of a certificate that somebody's going to carry forward. So forget about creditable coverage in July, but you're going to see some parallels to a new concept that we're going to talk about later.
Yeah. The third item is the annual limit on plans. Where plans used to have $1 million, $2 million, $3 million annual limit. That's all gone away. There's still some plans that are out there that are grandfathered that will phase in through the rest of the year, but for AHP, that has been in place. We don't have a limit and will not have a limit on the lifetime or annual benefits that are provided. The fourth item on here is one that I'm going to tell you about it, and I'm still struggling to figure out exactly what it is. We've told you before that
it's one of those moving targets.
It is a definitely moving target. The waiting period limitation that PPACA provided said that you could not have an individual be held out for more than 90 days. And as we talk about some of the other areas in reporting, you'll see the inconsistencies in the law in that this was a 90-day deal. And for most employers, like AHP, that have coverage that begins on the first day of the month, 90 days, counting actual 90 days sometimes created a problem, because if you have a 90-day wait and they come in on the first day of the month, obviously you've gone beyond the 90 days. In prior webinars, we talked about the concept of moving it to 60 days to ensure that as long as an employee had a 60-day waiting period and they came on the first day of the month, we would be protected in having them be within the waiting period that was permitted. And it's measured from the first day of eligibility. About 3 weeks ago, the IRS came out with the IRS, HHS, and DOL. They all kind of act simultaneously. They came out with a new interpretation of what this means. And I think it was because they finally understood that the majority of plans start people on the first day of the month. And because these laws are written by people in Washington who don't work with this on a day-to-day basis and have never seen a health plan in real operation, they don't understand how the pieces fit. So when they realize that this is going to create an issue, what they've come up with in the new regulations is they said, okay, there is still a 90-day wait period because that is what the law says. However, you don't start to measure the 90-day period until the expiration of a, quote, bona fide documented orientation period. When you read the regulations, and we were in Washington, D.C. a couple weeks ago and heard the regulators speak, and what came out of it is that wording that you see on that slide is exactly all that you see in the regulations. It is an undefined thing. We don't really know what it means. I can tell you that it can't be more than 30 days, but what it does is it moves the starting counting date. So if you have a bona fide documented orientation period, you don't start to count the 90 days until the expiration of this bona fide documented orientation period. We're working on the AHP side to figure out how we're going to build that into the document so that an employer that is going to use that concept is able to use it and has the ability to rely on that as a moving date instead of the higher date being the date that you look for eligibility. It's going to be the first day after the end of this bona fide documented orientation period. When I do the math and I look at this thing, what it basically comes down to is we're back to where we were.
That's right.
You know, whether you say it's a 60-day wait period with a 30-day bona fide orientation period, you're still at the 90-day period.
I think the one thing that we're kind of struggling with is, I mean, nobody really knows what a bona fide documented orientation, we don't really know what that means.
And I don't think the regulators do either, because I think they drafted the language very broadly. I think they're going to wait to see how it's implemented and see what
how
people
industry
do
reacts
with it.
To it. Yeah.
They purposefully did not define it. They have some conditions, you know, quote, it can't be a subterfuge to avoid the 90 days. I don't know how it can be anything but that, but you know,
that was their intent.
And that's the intent, but they,
honestly,
you know, you're supposed to comply with this, can't do this. I do know the only real fact on it is it can't be more than 30 days. And that's really the only thing in place. But we are going to include that in our document. I'm struggling to define it because, like I said, I don't have any real guidance as to what they think it means. So what we're going to come up with is what Maria thinks it means. And as long as it's a good faith interpretation of what their term means, I think we're going to be okay.
I think bottom line, I mean, most of the Advantage Health Plans, banks and employers did not have a waiting period in excess of 90. I think a majority of them did not. There were maybe a couple that did have something over 90. I think some of you all, based on our recommendations, have moved your 90-day wait to 60. I think this gives us a little bit of wiggle room if the 90 days was just incredibly important to you and in your business practices. But I think at least right now we would just be cautious of extending that from 60 back to 90.
Straight up.
Yeah. So you really kind of need to be able to stay within this new bona fide orientation period, safe harbor, if you will. But there's just, as Maria said, there's just not a lot of definition as to how do you fit into that. So.
And I would ask if any of you have some kind of a time period that you use just flat out operationally that you work with where you have what I would call this waiting orientation, I mean, whatever the term would be. But if you're using a time period right now that you use to kind of say nothing counts until you get to here, I'd like to hear about it. Anything that's actually an operation that you're doing would be valuable to me to understand how it works. So send your comments in to Megan and she can forward them to me so that I can see what you guys are doing. But this is an example of where there's a lot of frustration. I sense it in employers in trying to understand what they're required to do because employers are trying to comply. I sense it in the administrators that are trying to put it together because they're trying to comply. And this is one of those things where you think it's written in black and white, and then the last minute they come out with this change, and you're like, okay, so what does it mean? And no one knows, and no one can explain it. So we will define it for the government. The last item on here is just a reminder. Those of you that have flexible medical spending accounts, there was a change made last year that the government said you could carry over balances, and that is different than what we've historically had where there's a grace period. The difference between them is the grace period meant that if you were an employee and you had money in your account that you had not yet spent, as long as you turned your invoices in for expenses that were incurred before the end of the year, there was a time period after the end of the year in order to process them. That was just a grace period to get the documentation in to be processed for that prior year. The new one is really a carryover. If you didn't use it, the law now allows you to carry some of that money over and actually apply it to expenses in the subsequent year. The limitation on that is $500. It is an either or. You cannot do both. You can only do one or you do the other. If you want a carryover and don't have it in place, you need to make sure that the plan documents are amended before the end of the year, because that is one of those things that has to be in writing, and it needs to be done prior to the end of the year to go forward with it. So if you guys have any of these plans and are considering changing from a grace period to a carryover period, please let someone know early on, because these amendments need to be made with enough time to be able to put them out there before the end of the year. The one tricky thing about it that you may have, hear people talking about is this concept of giving employees a right to waive the carryover period or waive the carryover amount. And as we talk in that later on some of the benefits and what employees are going to have to demonstrate that they have coverage, to comply with their obligations on the mandate. One of the things that comes up is that if they have coverage under this plan and they have a $500 balance carried over, they are considered to have employer coverage, and it will affect what they can do in terms of subsidies and premium credits that they get on the exchanges. So it's not an option. You have to give people the right to say, I don't want to carry my balances over. It's a new concept. It's kind of a crazy concept, to be honest with you, but it is in place and it is workable. It can be done, but it does need to have a little bit of pre-planning and a little bit of advance time to make sure that it is documented properly. Failure to document that part is not going to be good. So again, if you've got those FSA sitting out there and you have a grace period, or you don't have a grace period and you want a grace period, or you have a carryover and any of those changes, make sure that you communicate with the account manager so that someone can get on it and make sure that the
make sure
changes
your
are done.
amendment is correct, yeah.
Yeah. That was one of those new things that popped in at the end of the year last year.
That's right. Yeah. We didn't have anything else to do.
I think the biggest thing that has hit in terms of the plan from a benefit deal at the ACA is this concept of the maximum, I call it, federal out-of-pocket limitation. It is in play for 2014. For Advantage, it kicks in July 1 of 2014. And what it basically is PACA has a provision that says that employees that are using your health plan aren't going to be required to be out-of-pocket monies more than the designated amount. These are going to be moving numbers for 2014. You see them on the screen at $6,350 for single coverage or $12,700 for family coverage. Those numbers for 2015 are already out, and they're listed there as the $6,750 and the $13,500. There's a couple of intricacies to this concept that are kind of, one, difficult to really administer, and two, actually put in play. First thing is, it only applies for things that are covered in network. Anything that's covered out of network, regardless of whatever the amounts are not subject to these limitations. So an employee that actually goes out of network and has $20,000 worth of out-of-pocket, that doesn't get covered. It's not required to be covered, and it will not be covered.
And that's actually an important point to make. I mean, all through the Affordable Care Act, when they're talking about certain benefit provisions, or for instance, in this situation, the new federal out-of-pocket maximums, the concept pretty consistently is everything that the ACA comes and changes only applies to in-network utilization. So whether it be preventative care or it be this 6350 limit, if that only applies if the patient is incurring that medical service in their PPO network. If you're out of network, the ACA doesn't really, they don't really care. There's no patient protection whatsoever. So a plan can pretty much do anything that they want negatively to a participant, and it is okay by the Affordable Care Act as long as that if that participant is being is seeking care outside of their network. And you all may or may not have been hearing through the news media that the concept of narrow networks, or having networks that have fewer choices, that really is what this has to do with. There's a couple of areas in the ACA that since everything's focused on in-network utilization, if you want to be able to contain costs, this is the out-of-pocket maximums are a limiter on the ability to contain costs. As we've talked with the Advantage Health Plans trustees about how this is going to impact Advantage and rates and things in the future, I've tried to make them understand that, we are losing cost containment tools. Out of pocket was always a cost containment tool to be able to incentivize people to go into network or to stay out of network. Nowadays, since everything only applies to in-network, one of the tools a new tool that you have, because you're kind of forced to use it, is by limiting how comprehensive a network is. So just kind of remember that as we walk through some of these benefit changes.
And, from a media point of view, if you've heard the stories about hospitals being cut out of plans, or providers, doctors, physicians being cut out of plans, that's exactly what they're doing, is they're restricting the network in a manner that forces the more expensive facilities to be out of network and therefore not subject to the cost containment that PPACA built into it. And it is an issue that I think is going to be a big issue. I think in 2014, it's just the glimpse of what it is. It's the tip of the iceberg. I think 2015, when the new exchange plans roll out, I think you're going to see even more limited networks because it is one of the only few tools left to be able to contain costs within a health plan. And, if you think about it, the cost containment feature in a health plan is the only way that you have to ensure that the overall cost to the employer and to the employees is contained at a lower level. So while they're containing in PPACA the amount that an individual pays out, they're trying to keep the premium cost or the employer contribution cost down. It's hard to do when you eliminate.
Mutually exclusive.
It's almost mutually exclusive when you eliminate these tools that were out there to incentivize people to reduce the cost. The dollar amount is going to be in-network only, and it includes deductibles, copays, and the plan out-of-pocket. And please note that I say the plan out-of-pocket as opposed to the federal out-of-pocket. I think there's some confusion in the marketplace where people think that once they meet the plan out-of-pocket limitation, that they're done. And that's not what the law says. The law says you can't exceed the $6,350 or the $12,700. So in a plan that has a very low deductible and low out-of-pockets, there is room, and you'll see it on the example at the bottom. If you have a $500 deductible plan with a $2,000 plan out-of-pocket, the total amount is $2,500. The difference between that and the $6,350 is a big gap. So in my opinion, the federal limitation says you can't go to the $6,350, so you can continue to have these out-of-pocket, the copay amounts that are charged to individuals. Not disallowed amounts. I'm only talking about actual copay amounts. Remember, disallowed amounts are out-of-network numbers, and those don't count. But the copays, the office visit copays, a surgery copay, a hospital copay, any amount like that where an individual has to pay actually out of their pocket, they got to come up with some money to go get this. Those things are supposed to count.
Those will be accruing towards the 6,350. But so right. It's kind of, Marie's absolutely right. I mean, the media, they gloss over things so much that I don't think a lot of folks really get the joke that you may be maxed out and you're within your plan's out-of-pocket max. However, you still have room to go to reach the 6,350 federal limit, and so people could still be being charged copays and co-insurance, or not co-insurance, but copays and things like surgical copay and
Yep.
things like that.
It's the copays primarily that are going to kick in. Prescription copays don't count in 2014. They are supposed to start counting in that same the accumulator for 2015. I think that is going to probably be one of the biggest changes that every health plan has to deal with, because prescription is a very large component of the total cost of the plan. You know, even in AHP, the percentage of the dollars that go out for prescription drugs is a very high percentage in comparison to the total.
And growing.
And continues to grow, and especially with the RX marketing that you see. I'm always amazed at how many commercials I can watch in a basketball game, and they're telling me all these drugs I need to go get. And all of the drugs that they're promoting are the more expensive drugs that are out there, not generic brands. They're the higher cost drugs. So in 2015, in theory, the industry is going to be at a place where the accumulators are going to be able to be tapped, and all of those amounts are going to be included. That affects the way that you design plans, and it affects the way that you administer plans, because it will be easier to get to those numbers once you start adding the RX copays that are built into it. And I think one of the things that you're going to start seeing is, and Advantage is in the process of kind of analyzing what it needs to do in terms of ensuring that it complies going forward. And one of the things that I think is happening is, and I see it in the exchange plans already, RX prescriptions are starting to be limited to generic drugs only, and anything that's not generic is an out-of-network. And that makes sense when you look at these things, because if it's out-of-network, it doesn't count. You can do whatever it is. So if it's in-network, then you count it, but if it's generic, then you may have some
We're not
issues.
discussing that right now, though.
We're not. That's what's happening.
But it is out
marketplace.
there,
It's the things that people are trying to grasp, to understand how it works. In 2015 will be the year when some of those changes hit the marketplace. So keep in mind, when someone reaches the plan out of pocket, it does not mean that they've satisfied the PPACA out of pocket. That's why I call it the plan out of pocket and the federal out of pocket. To me, this is probably one of the biggest areas that everybody's trying to grapple
Yeah.
with.
And this, Marie had mentioned that, some of these things have created administrative challenges. This is one of those right now, being that Advantage is a fiscal year plan, that this limitation kicks in for Advantage, or this new change kicks in July 1 of 2014. It's created an administrative problem for us, because we do have some plans that are within Advantage Health Plans right now that some of our bankers are on, that have an out-of-pocket max in excess of the federal 6350 limitation. We will be in compliance with the 6350 and the 12.7 for family, but how we administer it, at least for the next 6 months, is kind of creative. But the way that we have envisioned that this is going to occur is, we are going to be monitoring claims that have been incurred from July 1 to the end of the year. And within those claims, not just deductibles and co-insurance, but also co-pays, et cetera, we're going to be accumulating those. And if at the end of the year, at the end of 2014, if we see that there have been some participants within Advantage that have had claims in excess of the 6350 or the 12.7 for family, Advantage will be issuing what we call it, a rebate or a refund or whatever, for the amounts of out-of-pocket that were in excess of the federal limit.
In reality, I think, when you look at healthcare overall, it's really premised on a statistical evaluation of what happens. And so It is anticipated that not every participant will reach those limits. It's the ones that have the real high-cost claims or very serious medical conditions that will. So it's not everybody in the population of covered individuals that will bust these limits. It's going to be a handful of people.
Yep. Come 2015, however, we are going to then will be accumulating. Not only will we be accumulating from January and from 2015 and on, we won't be doing this 6-month accumulation. It'll be just on a calendar year for Advantage, and also, and we'll talk about it a little bit later in the presentation, But those plans that are offered by Advantage that do not comply with the 6350 or in 2015 the 6750, those plans will be modified to fall within the 2015 PPACA federal limitations. It'll cause some change. Some plans will be altered. Actually, a couple of plans are going to be consolidated, and we'll talk a little bit about that more in the future. But just everybody rest easy that for this kind of special fiscal plan year induced accommodation that we've had to make. Yeah. That's how it's going to work for the remaining 6 months of 2014, and then in 2015 it'll be a much more straightforward type of situation that folks out-of-pocket maximums will be limited to the 6350 and the 1350, and that's going to count all expenditures that are covered. So things that are just not covered by the plan don't go toward that, obviously, but things like copays, even drug copays in 2015, all of that will accumulate towards that 6750 and the 13.5 for family in 2015. Hopefully that's clear as mud, but if you have any questions, ask us at the end of the presentation.
It's quite a challenge to implement this stuff, especially in the middle of the year, middle of a calendar year. Yeah. That kind of is all of the stuff that we were going to talk about in terms of the benefits, the ACA benefits.
Yeah, benefit changes.
It changes, AHP is pretty much in compliance with covering what it is required to cover. The second piece of what we were going to talk about are the taxes. And the first one I'm going to talk about are the taxes on what they call the individual responsibility. You've heard them as the individual mandate. That tax is in effect for calendar year 2014. This is a tax that applies to the individual, to each employee, to each dependent. It applies to the individual. It is not a plan tax. It is not an employer tax. This is the individual's responsibility to have health care coverage. The concept behind it is that everybody is supposed to be responsible and participate in this nationalized healthcare approach to healthcare, and therefore every individual is required to have coverage and participate by, in their mind, goal-wise, by buy-in policies so that they contribute to the pot of money that is used to pay for the sick people. If you've been watching the news, you've been hearing a lot about the push that hit the exchanges in March, where they were trying to enroll the young population. And the reason for that is the young population is the one that is the most reluctant to buy health care because they tend to be the healthiest and don't need to really utilize the benefits that a health plan provides. They want catastrophic stuff. And so the goal is you start participating, you put your money into the pot because we're going to use your money to pay for the sick people. And the individual mandate then is the penalty that applies if you're one of those people that chooses not to get health coverage. So on this mandate, what they're talking about is individuals who did not have health care coverage that the government deems as to be coverage. And if you don't have it, then you're going to be paying this penalty. It's going to be reported on the individual tax return. So when individuals file their 1040s for 2014, there will be a box on the 1040 that is going to ask them whether they had health coverage. And if it says no, I guarantee you that TurboTax is going to add a penalty to the computation. The interesting thing about this, and this is one of the complexities in the way the law works, is that these taxes are actually imposed on a month-by-month basis. So you can see how it's going to be very difficult to make sure that there's information provided to indicate which months you were covered and which months you didn't have coverage. I haven't seen the 1040 changes yet. I don't think the IRS has generated them, but they are working on changing that form to ensure that that is reported. The tax is, the $95 in 2014. It's $95 per adult plus $47.50 per child, with a maximum $285 per family, or 1% of income, and that's 1% of the adjusted gross income. So if your adjusted gross income is $100,000, your penalty is $1,000. Numerically, the numbers are still small.
Right.
They're not that great of an incentive, really, if you think about it. Paying a $1,000 penalty or an additional
Compared
tax
to the
of
cost of
$1,000,
coverage.
it's a lot cheaper than buying health care. It's going to be a challenge. The numbers are going up in 2015 and 2016 as they are trying to encourage people to get on board and start providing their share of their money into this pot to pay for everybody else. One of the things that is kind of interesting in there is that there's a lot of exemptions. There are hardship exemptions. There are a number of exemptions that people can use through the exchanges. I made a list of them. It's a long, long list, but just to give you an example of the kind of things that are out there. If you're incarcerated, obviously you're not subject to it. If you're a member of a federally recognized Indian tribe, you're exempt from it. If you're a member of a religious organization or a sect that opposes the use of health care, you're exempt. But then they added some other creative ones, like if you're homeless, you're exempt. If you've been evicted in the prior 6 months, you're exempt. If you've had a shut-off notice on your utilities, you can have a hardship exemption. If you've been involved in recent domestic violence, you can be exempt. So you can see the list is, it's out there on the exchanges if you go look and try to see what's available as a hardship, and there are forms that you complete. But the list is long and it is growing, and I think it will probably continue to grow. And the goal is they're trying to make it soft for people that are perceived to be in a financial situation where they can't afford health care. Now, to me, that just kind of eliminates the whole concept of everybody's responsible and everybody's got shared responsibility. But the exceptions and the exemptions and the hardship conditions have continued to grow this year. And I think I would expect them to grow even more for 2016 as more and more people raise other things that they would like to raise as reasons why they shouldn't be subject to it. Right. The thing that's interesting about it, we've talked about this before, is there really is no mechanism to actually collect these amounts. So even though an individual files and says that they're required to pay it, unless you've overpaid your taxes and they have money coming back to you, they can reduce it from a refund, but they really have no mechanism to go out there and collect these monies. The second part of the taxes is on the employer side.
We'll start getting into the fun part.
Yeah. These are kind of fun. For AHP, for employers, actually you're in a pretty good place. We've got 3 big ones well, 4 big ones that are really hidden this year. The medical device tax is a 2.3% tax that is in effect on medical devices. That is already being seen because it is charged through the claims process where the claims are including the additional cost of this 2.3. There's been a lot of talk in Congress to repeal that. There are a lot of people that don't like this concept. There are several bills out there that have tried to do away with this. As it stands today, it is in play. I wouldn't be surprised if by the end of 2014 there is a change in the law and they retroactively refund all of these amounts. But for now, that's in there. The employer taxes, the ones that you probably have heard more about, are 3 types. One is the HIT tax, which is really primarily on the fully insured. It's the insurance companies.
The HIT tax is health insurance tax.
The health insurance tax, and it's 2.5%. It falls primarily on insurance company. Advantage Health Plans is one of the exceptions. MEWAs are subject to it, but there's some limitations, and it only kicks in when your revenues are at above 25 million. I would expect AHP will have some amount to pay this year, but not a very large amount.
It'll be a very small percentage.
For us, it's very small. But the fully insured market, that is a cost that they're adding on the premiums because that is a cost to the insurance companies that they're paying. The ones that affect you more directly are the PCORI and the reinsurance tax. The PCORI tax is that Patient-Centered Outcome Research Institute.
Very good.
And as I've told people over and over again, and they think I'm nuts, I think the Patient-Centered Outcome Research Institute is the arm of PPACA that will, at some point in the near future, really be limiting care. Their concept is basically you're going to evaluate what it is that is patient-centered, outcome-focused, and if you think about it, the sicker you are, the more things you need, the less effective they are, and you start to go, whoa, it's healthcare rationing.
Yeah, it's looking at providing healthcare when there's an appropriate ROI. And that's kind of hard to think about and get your mind wrapped around when we're talking about human beings. But that is what PCORI is about. Is a hip replacement on an 80-year-old. Is that a good return on the country's, the taxpayers' investment? We find it pretty offensive, but we don't get to vote on whether we fund PCORI or not. It's part of the deal.
Yep. It started in 2013 for plans that had years that ended between October and December, and those plans filed last year. It's filed on an excise tax form, the 720, only in the second quarter. For AHP, AHP will do the filing, AHP will pay the funds. You as an employer will not be required to file your individual 720s, and you will not be paying the tax separately. It is built into AHP itself. If you have some other health plans that are outside of AHP, you might want to take a look at whether or not they are part of the AHP plan or integrated with it. If they're not integrated with AHP, you need to look and determine whether or not that entity would be required.
Talk to your insurance company or your administrator of those other plans.
Of those other plans, yeah. But, for you, rest assured that AHP is going to do the filing this year, and we will be paying for this year. It's a $1 per belly button, not per employee, but per belly button, which means every covered person. Next year, in year 2, it kicks into $2. So for the people that filed in 2013, they'll pay $2, and the rest of us will pay $1. I'm still waiting to see the 720 from the IRS. They have not issued the revised form that includes the $2 cost in it. The reinsurance tax is the one that is a lot more expensive. That's the one that is the $63 per belly button, per member, per covered person, not per employee. It is a 3-year base period. 2014 is year 1. It goes through 2016, and the numbers in theory go down. I had Megan put in those numbers down there so you can see the impact of what they're actually talking about. PPACA, unlike most laws, actually designated an actual amount that is going to be collected from all these health plans, and it applies to the fully insured plans and to the self-funded plans. And in year 1 in 2014, they are expecting to collect $10 billion, which Health and Human Services is going to then take and redistribute to insurance carriers with plans on the exchanges to help them minimize their cost of adverse selection.
The cost of taking on bad risk.
The cost of bad risk, which I think when all is said and done, I think you're going to see the exchange plans have a very high adverse selection population in it.
Well, several states have already abandoned their state-run exchange because of this very thing.
They can't make it work.
No.
The amount includes the $10 billion, which is all those zeros. It includes an additional $2 billion that goes just into the general coffers of the government, and then they have a $245 million administrative fee. The $63 is an estimate as to how they're going to collect that $12,245 million amount. How they really came up with the 63, I'm not sure that I could tell you. I don't know if it's enough, I don't know if it'll be too much, and I don't know if it'll be too little. In 2015, the amount decreases to 44, at least for now, that's the expectation. Late last year, the administration put out can't remember if it was a notice or a frequently asked question. They issued stuff in such an odd way that I can't remember what mode they used, but they attempted to exclude some self-funded health plans from the requirements to pay the reinsurance tax if they were self-administered. Unfortunately, I think the administration has finally realized that there really aren't that many self-administered plans. Most employers use some kind of a TPA or somebody to help them do this.
Even the union plans do.
Even the union plans, which is what they were trying to appease. So when they look at these $44 per member, I don't think they have a belly button count to know how it really fits, and my guess is those numbers are subject to adjustment. From your chair, again, you will not have to worry about reporting on this reinsurance tax. You will not have to worry about paying the reinsurance tax. It will be done by AHP, where AHP will do the filing and AHP will actually do the payment amounts. So it is not an employer tax at your end. In the fully insured plans, it's the insurance company that is doing it, and they are collecting these fees as part of their additional premiums on the plans. That one it's a big hit for this year in terms of dollar amount. $63 per belly button is not cheap for Advantage Health Plans Trust.
In the irony, I just can't not comment on the irony that our bankers' health plan is, as the bankers have chosen to self-insure their benefits through Advantage Health Plans Trust. Generally those employers have chosen to become part of Advantage because they've chosen not to be with an insurance carrier. And in this situation, your self-funded health plan is being taxed, and those funds are going to the insurance carrier. It's a strange world that we live in today.
It is a very strange world. The other tax that's out there is the one that we're going to come to, which is it hits employers, and I have to kind of give you a sense of this terminology, because when I read it, I have to stop and look and say exactly which phrase am I reading. In the media, some of this information is kind of all lumped together and it's not articulate.
No, I mean, this slide right here, folks, is something that we really, if you can just sit still for a minute and really pay attention. This is a very simple slide, but we get calls literally every day, and a lot of those calls are centered around the confusion that's generated between this terminology that is on this slide, because these things are different. It looks kind of like word salad. It looks kind of like the same stuff with the words turned around a little bit, but these are different concepts. So we're going to see if you can shed some light on this for us.
I want to give you the difference between what's the self-funded arena and what's on the exchanges or the marketplaces, which are fully insured plans. Okay, if you look at what the exchanges offer, they offer individual policies. They're not group policies. They did not do group stuff for this year. So these are all individual policies. On the exchanges, and exchanges and marketplace, they're the same thing. It's a matter of how they're how it's being spun out there, but it's the same thing. Exchange plans have to offer what's known as the minimum essential benefits. The minimum essential benefits, we're going to go into it and show you what it is, but minimum essential benefits is the standard of the healthcare that PPACA requires every one of these fully insured policies on the exchange to include. On the self-funded arena, we have minimum essential coverage. They are not the same.
And beyond that, but minimum essential benefits is what is actually in the law. Essential health benefits is a term that's been made up by the media. So they'll use minimum essential benefits and essential health benefits interchangeably. So when you hear essential health benefits, you need to know that they're actually talking about minimum essential benefits as it refers to the individual policies that are available on the exchange plans or the marketplace plans.
Yeah. In the self-funded plans, you have what's known as minimum essential coverage. And the self-funded plans are required to have minimum essential coverage that has minimum value and is affordable. And those components are real important from an employer point of view, because employers are going to be subjected to what we've talked about before as the pay or play penalties. And this is the component that says when you're an employer that has 50 or more full-time or full-time equivalent, you're going to be subject to these taxes if you don't have minimum essential coverage. You get one layer. If you have minimum essential coverage that doesn't have minimum value or affordable coverage, then you get a different kind of penalty. But if you offer this, then you get out of the pay or play penalties. And this is why it's important for you to understand the difference between this minimum essential benefit, minimum essential coverage, because the minimum essential coverage is what impacts you as an employer to ensure that you're not subjected to those penalties under the pay or play rules that apply to the employers.
So hopefully if we have got our language straight, let's move now we're really going into the weeds.
Now we're going to tell you what this is. Okay, minimum essential benefits. Remember, these are the exchange plans, the marketplace plans. And this is the list of benefits, actual medical benefits that these plans are required to have. The interesting thing is the statute actually lists those 10 categories that you see there: the ambulatory patient hospitalization, the mental, prescription, preventive, pediatric, services for dental and vision, lab fees, rehab and habilitative services, maternity, newborn care, and emergency services. Every exchange plan has to have those benefits. What they didn't define is exactly what does that mean. And so what they came up with was to say, well, it's based on your state's benchmark for what these benefits have historically been. And so every state benchmark is not identical. In most cases, most well-designed health plans really have offered probably 9 out of those categories, or 8.5 of those categories all the time. Advantage has always had the ambulatory patient services. They've always had hospitalization. We have had mental health and substance abuse benefits on an equal basis with the regular medical procedures for a while now. It's always had prescription drugs. We've always had preventive services that have been built into the designs of the plans. We've always covered emergency.
Long before they were mandated.
Long before they were mandated. We've always had emergency services. We've always covered maternity benefits because there's a separate law that tells you have to. We do all rehabilitative. We've not always had habilitative, and I'm still struggling with what exactly a habilitative procedure is. We've always done lab. We've never provided dental or vision benefits for children, and by this, children in this case means 19 and under. In the insured market,
Under the health plan,
under the health plan by itself,
not the dental plan.
that's a separate benefit. You've always had the dental. You've always had some vision on the side,
Yeah.
but it's never been a part of the medical plan. So the important thing for you to realize is when we're talking about this essential health benefits, that's the insurance plans on the exchanges, the marketplace. They have to have all of those 10 areas covered. It's not an option. They have to have all of them covered. What they cover within each area is based on whatever the state level is. For Advantage, we don't have to offer essential health benefits in the sense that we do not have to include all of those 10 categories. What we do know is that if we have, for example, hospitalization benefits, which AHP has, we can't have a dollar limit on it for the year. We can't say we're going to do up to $500,000 for health, for hospital coverage. You can't put a dollar limitation on those benefits once you have them in, but Advantage Health Plans is not required to include every single category that is listed on that essential health benefits list.
But
Okay.
if we were to, we couldn't have a dollar limit on them.
Right. And that's kind of how the pieces are fitting together. So this is the insurance standard that they have to comply with on the exchanges. Now, let me switch over to the next one. Now we're going to get to the plan side of it. Advantage is a self-funded plan. So it has to be minimum essential coverage in order for you as an employer to be able to work with the pay or play penalties that hit, okay? Minimum essential coverage is...
This, and I might just introduce, this, for the next few slides here, folks, if you've been asleep, these are the ones that you want to pay attention to, especially if you're an employer that has over 50 full-time or full-time equivalents. This is kind of the punchline where I think most of you all probably have tuned in to hear about these different layers of penalties and how you avoid them. Sorry.
Yeah, no, that's good.
Try to frame this correctly.
Yeah, I was trying to recall when we did the pay or play webinar, we went through
A
the
lot of
sledgehammer
it's
stuff.
changed, yeah.
Some of it has
since
changed.
then.
It's different. But if you will recall, the concept behind this pay or play penalty was that if you're an employer and you choose not to offer any health benefits to your employees and their dependents, then you as an employer ought to have this shared responsibility where you're going to kick money into the pot. You know, just like at the individual mandate, if they choose not to have coverage at an individual level, they have to pay this mandate in order to put money in the pot because they're not contributing, if you would, to the overall dollars going in to pay expenses for medical claims. The same concept carried over to employers. If you didn't offer your employers minimum essential coverage, then you then are subject to the rules because you are not doing your share. You're not complying with your responsibility, and therefore you're going to be subjected to the penalty. So the first layer of it is, if you're an employer that is 50 or more full-time employees plus full-time equivalents, you got to get that concept in your head. This is a concept that applies only to this pay or play penalty provision. These taxes, and in Washington, actually, they're not taxes, they're assessable amounts. If you're an employer, when you add your full-time employees and you add the full-time equivalent, and the number is 50 or above, this is a tax that applies to you.
If you're not, this does not apply to you.
Right. If you have 30 employees and that's it, this tax doesn't apply. It's only when you have the 50 equivalent and full-time that you are then subjected to this tax. So the first layer says that if you are one of these employers with 50 or more full-time plus full-time equivalent, then you must offer minimum essential coverage to all the full-time, not to every employee, only to full-time employees. Statutorily, they're defining a full-time employee as one that works on average 30 hours per week. That number is still being contested. There's stuff in Congress trying to raise that back to 40. I don't know where it's going to be between now and the end of the year. It would not surprise me that it goes up. But if you're in this class of employers, you have more than 50 full-time plus full-time equivalents, then as an employer, you are required to offer minimum essential coverage. And this is going to be, I think, if you don't mind, let me just finish this.
Sure.
I'd like to do it. It's going to be real important because as employers are looking at what's happening in the healthcare, despite what the goal was of healthcare costs are coming down, there is no way to continue to bring healthcare costs down when you have no cost containment features and you're adding all this other layer of regulations in terms of reporting and the benefit structures that you have to have. And so some employers are going, the heck with it, I'll just stop. I'm just not going to offer anything. And this is where your employers are evaluating whether they even want to play in the healthcare business or say, fine, I'll just pay my fine. The ones that choose not to, the penalty is a $2,000 assessable amount if you're in Washington, a tax or penalty if you're in my head, for every full-time employee that you have. There is by statute, or I think by regulation, they excluded the first 30, but then you're on the hook. You're going to be reporting it, and when we get to the reporting information, you're going to see how they're linking all of the data to be able to figure out whether you're an employer that's going to be subject to this penalty. If you offer coverage, and I can tell you that anything you offer as healthcare coverage, so long as it doesn't have dollar limitations and it offers at least preventive services, then you have minimum essential coverage. So minimum essential coverage has nothing to do with that group of minimum essential benefits where you had 10 categories of benefits. If you offer preventive services only, you technically have minimum essential coverage.
Every plan offered under Advantage Health Plans provides minimum essential coverage. So if you're a member of Advantage Health Plans Trust, then you are currently offering minimum essential coverage. It is that minimum compliance level that gets you out of what we have termed the sledgehammer penalty, because it's the bigger of the two penalties. Now, as I was trying to interrupt you earlier, I was just I wanted to make absolutely sure. In fact, Cindy in our office has threatened that if I don't bring this up, she's going to come looking for me. But a lot of our bankers get very, very confused about the full-time plus full-time equivalents and what does that mean. So I want to kind of step through it just briefly with you all. The first line of the very first bullet where it says all employers with 50 or more full-time or full-time equivalents must offer minimum essential coverage. That 50 full-time plus full-time equivalents, that is the test to see whether or not you are subject to the minimum essential coverage sledgehammer penalty. So as Maria said, if you go through that test and you find out that, yes, I am subject to this, then you only have to just offer a plan that has minimum essential coverage only to the employees that work at least 30 hours a week. And I think where some of our bankers have gotten confused is if I am subject to this, I have to offer coverage to my full-timers and my full-time equivalents.
No.
And that is not correct. Again, the full-time equivalents, you only take that into consideration when you're determining whether or not this penalty or this concept applies to you or not. If it does, then the full-time equivalents go out the window, and we're only needing to be able to prove that we're offering coverage to those that work at least 30 hours per week. And again, it's just offering. They don't have to take it. They can go and do their own thing, and you're fine as long as it's been offered.
Yep. And the way that Advantage dealt with this situation is, if you recall, last year we instituted that open enrollment period that came in November through mid-December. And the purpose of that open enrollment period is to ensure that you as an employer have documented that you have offered the coverage. That's what open enrollment does. It is the opportunity to offer coverage. And once you offer coverage, then you have met the minimum standards that you're required. You have minimum essential coverage because all of our plans meet that standard, and you have offered it to all of these full-time employees. So you're covered under that. In 2015, this rule was supposed to kick in 2014. And as we were all trying to gear up and figure out how this is going to fit and how it's going to work in real life, Washington decided they really didn't know either, so it got delayed. So it's not in play for 2014. And the employers, no employer, whether you're under the 50 threshold or above, doesn't matter where you are, the tax is just flat out not imposed for 2014. It will come back into 2015, but it came back in stages. So what the government said is, if you are an employer that has, and remember, this just comment, if you have the 50 full-time plus full-time equivalent, you're going to be evaluating whether or not you're subject to this tax. If you pass that threshold, then you look at it and say, if you have 100 or more full-time and full-time equivalent, one rule applies. If you have between 50 and 99 full-time and full-time equivalent, a separate rule applies.
Except these are allowances or exceptions to the law, and that's what we have there in the
Right.
in the bullets in the middle. So we had as it was written, the first bullet. That's how it was written. It was all going to go into effect in 2014. Now that they've made some allowances, so now we're looking at some other tests to determine how the delay is going to affect your employer.
Right. If you're between the 50 and 99, the tax will not kick in until 2016. You're not subject to it at all. You will be reporting, but you're not subject to the tax. If you have 100 or more, the penalty, the tax, the assessable amount is in effect during 2015, and it will be assessed during 2015. So they bifurcated the group to change the levels. The one caveat I want to point out to you as I'm talking here, because I want to make sure everybody understands this, when you're looking at 50 full-time and full-time equivalents, be sensitive to the fact that you're not looking at branches, you're not looking at divisions, you're not looking at individual banks per se. You look at what I call as, the legal sense is the control group. And we've talked about this before, and it is a very fact-specific determination, but you need to understand that if you have more than one bank, that the ownership of those banks may cause you to meet that 50 or more number when you aggregate them. Even if your locations are not individually at the 50 or more, in the aggregate, you might be subjected to this tax because you have multiple banks, multiple branches, multiple companies that all come under the control group rules. So the control group rules are going to really kick in. For those of you that offer retirement plans, the control group rules are the same. If you've done an analysis of the control group rules for your retirement plan, it's the same analysis that you do for this thing. But it's real important to understand that that's the threshold. It's not just a location. We're not looking at employers by divisions, by locations, or even little sub-companies. If in the aggregate you have multiple entities that are all treated as a single employer, that number the calculation is based on the aggregate. Now, for 2016, for 2015, the tax is going to apply to those employers that have 100 or more full-time and full-time equivalent. But they changed it. Instead of having to offer us what the statute says to all your full-time employees, they came back and they said in the safe harbor, you only have to offer it to 95% of your employees. Now, for 2015, these employers only have to offer it to 70% of their full-time employees. So you can see where they're scaling it back and trying to give you some leeway to kind of get a little bit of room and breathing room to understand how it works. So be sensitive if you are one of these employers. A lot of people kind of, want to hurry up and comply. They want to get to it and just meet everything. But these rules are changing so much that if you try to comply with them from the very beginning of it, you can see.
You've wasted a lot of effort.
Yeah, it's harder. 2016, this is in full play. So 2015 is going to be the year for those employers that are over the 100. 2016, the rest of the employers that are 50 and up are going to get caught up in it, and it's a time to really evaluate where you are and make sure that you're complying with it. I think there's a possibility that they're really going to remove that 50 and move it to 100. There's a lot of talk with that, but you've heard me tell you this before. Congress doesn't operate very well right now. They're having issues with identifying what they can and can't change in Congress in terms of the laws. And there are bills to try to change this stuff. Whether they succeed or not, I don't know. It's possible.
Okay, so folks, this is the sledgehammer penalty. We're getting ready to move into the next, and this is what we know as of right now. Maria said there's bills in Congress. I actually, right before I came into this room to do this webinar, I was reading the latest SPBA bulletin, Society of Professional Benefits Administrators, and they were actually talking that there is a lot of talk in Congress right now about further delaying any implementation of the pay or play, and possibly even indefinitely postponing it. We're not betting on that at all. We are, this is the timeline that's in front of us. These are the things that we're going to be here to support you all with. This is how we're going to be rolling. But just bear in mind, early adoption, as Maria said, we've done bulletins on this, but early adoption of a lot of these things is not always in our best interest. We want you all to be very aware of it. Know that we're very aware of it. We are planning, but just because you don't hear something from us saying, "Oh my gosh, dude, this thing just came out, and let's take all these steps to implement this," we are being very, very cautious because we do not want to add additional workload to our bankers. Yep. For things that are over the horizon is not very far. So things are changing all the time. Now we're going to move in to the other test, and this all has to do with making sure that the employer's plan is meeting its responsibility to offer minimum essential coverage. And now we're going to talk about, okay, we've already assuming that we are offering coverage that is minimum essential. Now we're taking that a step beyond and saying, okay, we get it that it was minimally essential, but now does it provide a minimum value, and is it affordable? So now we have two new tests that we're going to talk about, and if you do not meet these two tests, then the employer is subject to what we refer to as the tack hammer penalty, the smaller of the two. The other one was the $2,000 applied against all of your employees, all your full-time employees. This is a test. If you bust this test, then the penalty only applies to certain individuals within your group. So with that, Maria, take us away.
Okay. This part of the penalty, again, applies only for the full-time employees who work 30 hours or more a week on average, that either get offered coverage because, like in AHP, they will have coverage offered. It is minimum essential coverage, so you're past the first threshold and you're into the second one. So now we're looking at whether or not employers will be subjected to penalties for those individuals who either didn't get minimum value or affordability, and they went on the exchange and they got a subsidy. In that case, then the concept is the employer needs to help to subsidize the cost of the exchange picking up the employee, and the consequence is that the employer has to then pay a penalty. These penalties, again, are $3,000, but only for those individuals who meet all of these criteria. They're actually assessed on a monthly basis as opposed to an annualized basis. And I say that to you so that you keep that in mind, and when we talk about reporting, you understand the complications in the reporting when you're assessing these penalties on a monthly basis, because that means you've got monthly information that you're going to have to file in order to figure out which months you might be liable for. But the two components here is, if you're one of these employers that's subject to the penalties, you have to have a plan that meets minimum value. Minimum value, and if you switch it back here for a moment, remember I had that little chart that said here's the marketplace, minimum essential benefits, and then we had the self-funded plan, and we had two boxes, minimum essential coverage, right there, minimum essential coverage, which is what we've talked about, and then the second box is minimum value and affordable coverage. That's the component we're talking about right now, that minimum value and affordable coverage. Minimum value. Minimum value is this computation that is done by using a calculator that has been developed. It's not an option, but it's kind of a requirement unless you get an individual actuary to certify your plan individually. Most employers are using the calculator. All of the AHP plans have minimum value. And that means that in the aggregate, using the assumptions that the calculator uses, the plan pays at least 60% of all the costs. And that's the threshold. If the plan meets this calculation that it actually pays at least 60% or more of all the costs, it meets minimum value. Now, this calculator is kind of a, trying to find a polite word, hokey kind of deal, because it's a fictional basis to measure. It does not look at the actual benefits that we offer through AHP. It has no weight given to the fact that we have premier providers where the benefit is at 100% and the employee pays nothing. There's no way to build that into the calculator.
This is the calculator. I mean, that's a pretty strong term, but that is what they call it. But it is essentially an Excel spreadsheet that has a bunch of hidden cells that are in it, lots of hidden formulas in it. But you get it, you download it off of the federal website, you plug in a lot of the plan parameters that you have. But as Maria said, there's no blank to put in a lot of the features, for instance, of advanced health plans or a lot of our other clients. So whether or not a plan has advanced premier providers in it or not, we know that when we added premier providers, that was a significant enrichment of the plan benefits. Right. It's a benefit expansion. But it doesn't move the needle at all because there's not even a blank to put a feature like that into the calculator. And Maria was being very, very, very delicate when she was commenting on the calculator. But she said, that it estimates 60% it covers 60% of the costs. Well, 60% of what costs, we don't know. It's really trying to approximate that. What is 60% of the cost? What does that equate to? Is that a good plan? Is that a bad plan? It really is trying to equate back to the plans that are going to be offered on the exchange or on the marketplace. The 60% level has been equated in the federal government's eyes as the bronze level plan, the bottom of the barrel plan that is offered on the federal exchanges. So that is that minimum value threshold. So your plan that you offer in order to get you out of one of the tests on the tack hammer penalty is, does your plan have coverage that is equal to or better than the base bottom plan offered on the exchange? I think the lowest plan under Advantage came back at a little over 70% of the minimum value. Many of the plans were approaching 90% on the minimum value calculator. So with that, go ahead.
Yeah,
I'm sorry.
and the minimum value, the one thing I want to make sure that you're all contemplating and understanding is some employers have the health reimbursement arrangements, the HRAs. Sometimes employers have the HSAs, which are for the high deductible, the qualified high deductible plans. And when the employer is making contributions through those items can be included to figure out whether the cost to the employee is lowered. And so they're included and they are treated as a component of the big plan. So you don't look at an HRA as a standalone plan for purposes of the penalty. So long as it's offered in conjunction with a major medical plan, the HRA is an element of that whole component and not tested separately. If you had an HRA with a fully insured plan, that's a different deal. It's harder to do. The second component is affordability, and we've talked about this in prior webinars where affordability is measured statutorily by saying that the cost to the employee can't be more than 9.5% of their household income. adjusted household income, which is the reporting information that comes on the 1040. Most employers don't have access to an employee's taxable income. And quite frankly, I wouldn't want you as an attorney advising you to get your employees' tax returns and try to decipher this, because that's insane. So what they came up with were some safe harbors. Two things that are important. One is the affordability test is measured only for the employee-only coverage. The dependent component of it is not a factor. So what you charge for individual coverage for the individual employee only is the only element that you measure to determine whether it's affordable. If the family coverage is 5 times that number, 3 times that number, that component is not built into the affordability test. The safe harbor that was developed by the IRS for employers was to say, if you have a plan where you are charging that employee no more than 9.5% of your employee's taxable wages, you are deemed to have met the safe harbor. And I want to make sure that you highlight and underline that taxable stuff, because taxable wages is not gross wages. It is literally box 1 of your W-2s. And that means that when you have the employee pay for health care, their cost of the premiums on a pre-tax basis, or you have the employee provide dependent care on a pre-tax basis, or you have an employee that participates in a 401k on a pre-tax basis, those numbers don't get added into box 1 of the W-2, and therefore that's not a component in figuring out the taxable wages that your employee has. So be sensitive to the safe harbor, application of the safe harbor. The other safe harbor is to say if you don't charge them more than what the minimum wage number is, which is about $89 a month. That is single only coverage, okay? Make sure that you get that. It's single only coverage. Most employers probably are within a pretty safe line on this. But assuming, hypothetically, that you've got those 3 employees and you are not at 9.5% of their taxable wages, you could be exposed to this tax hammer penalty for those 2 employees if they didn't take the coverage and they went on the exchange and they got a subsidy on the exchange. Then you might be subject to a penalty for those employees only, not all the full-time employees, only those that you didn't offer affordable coverage to. And the reason that that's important is because I don't think that we're ever going to eliminate complete liability under the pay or play rules. I think you minimize your exposure and you control your exposure by understanding where it is. And this is where you're going to see it. It's not going to be at whether you offer minimum essential coverage, because all of our plans do. It's not going to be at whether you offered it, because we have an open enrollment and we comply. It's not going to be at whether you offer minimum value, because the plans all offer minimum value. So the only place where you have, I think, some exposure is in whether or not what you're charging them is going to be affordable at the employee-only level.
It's the one piece that Advantage doesn't have any control over. That's going to be that piece is going to fall to the individual banks, to make sure that they are meeting that affordability test. Right. Okay.
And the other thing to keep in mind is it is possible that you have an employee who goes on the exchange. They actually go on the exchange and they qualify for subsidies based on their household income, but you satisfy those criteria. You actually have made it affordable. The fact that they got a subsidy doesn't penalize you. The only penalty you would have is if you didn't comply with your end of the affordability element. So what actually happens to them down the road on the exchange has no consequence to you at that level.
And that's a great point. In fact, I even wrote myself a note last night to hit that, and I'm glad you brought it up. We were introduced to a new term by the IRS in D.C. in the spring, and that is the idea of firewalling. And the IRS agent that was giving this presentation said that basically just what Maria had just gone through step by step is that if you are offering a plan that offers the minimum essential coverage, check. We are offering it to everybody through the open enrollment, check. We are also offering a plan that meets the minimum value at that 60% or higher, and under Advantage Health plans, everything that we offer will exceed the 60%, check. And you ensure that it is affordable, as we've described here on the slide. Then that employee is essentially firewalled, or the employer, excuse me, is firewalled from any type of a penalty for that employee. They can do whatever they want. They can take your coverage. They can not take your coverage. They can go to the exchange. They can go to the exchange and get a subsidy. No matter what they do, the employer is firewalled from any type of these pay or play penalties. So that's kind of an important, and that may not be the approach that a bank takes. I mean, it may be, we have a lot of employers that are wanting to have a deeper understanding, or wanting to manage their risk, manage their exposure. And hopefully you all have understood this to a level where you can see where maybe managing the exposure is the right choice for your bank. You may be in a bank where you just want to make sure that all your employees are firewalled, and so you want to make sure you check all those boxes. Either one are valid strategies. We see employers that do both of them. So I think we're ready to move on. And we're about 10 minutes from time up, so we're going to try to hustle a little bit, and I think we're probably also just going to go a little bit late, but anyway.
It gets simpler now that you got all this concept down.
That's right. Now that you know everything else there is to know, it'll be simple from here on out.
The piece that employers are struggling with is trying to determine who's full-time, who's not full-time. Are they 30 plus or not? And generally, I think that I can give you a little bit of black and white. If you have employees that you know are regularly scheduled to work 30 hours or more a week, they're full-time. That's it. They're full-time. You know they are. The ones that cause employers issues are the ones that don't work as many hours, or you don't know when you put them on whether or not they're going to be working an average of 30 hours a week. And for those, there are ways that you can monitor them. To me, and I think we did this in a prior webinar, the IRS Safe Harbor, where you do this measurement period with a bunch of stability stuff, that is very difficult, convoluted, and awfully complicated to apply. I think the most manageable form of applying it is to look at it on a month-by-month basis. When you have employees that are seasonal or part-time, and you start seeing the pattern that they're 30 hours, 35, start looking at them, because those are employees that you may really need to classify as a full-time employee. And once you see the patterns there, offer them the coverage, treat them as full-time employees.
Have to be able to document that you offered them. You've got to be able to track and measure this. But for a community bank, we kind of like the idea of, I don't know, Maria's probably got a different term for it, but I kind of call it, keep your part-timers part-time, keep your full-timers full-time. Don't have, if this is a strategy that you can support within your bank, then that may be a good one. Is who your seasonal, who your variables are. You don't intend to offer them coverage, and you just make sure that they do not approach the 30 hours a week, and you're safe. The folks that are regularly scheduled to work over the 30, that you're going to offer them coverage, and you offer them coverage as soon as they become full-time. And you kind of keep that separate. Yeah. If we were not talking to a bunch of community banks on Advantage Health Plans, which is going to be our next webinar at 1 o'clock for non-bank employers, the monthly look-back method becomes something that becomes more of a reality, where variable hour folks are more of a reality. Or you might want to add a little bit to this, but there are a lot of vendors out there that can assist employers, and there's a lot of vendors, there are a lot of folks that are out trying to sell everybody things. I mean, we could attend sales webinars once a week if we wanted to. All sorts of vendors offering you software to track this. We honestly think that the payroll companies are probably going to be payroll is the natural the natural location for this type of tracking and maintenance. If you kind of think about it, especially if you're doing the monthly look back method to determine whether or not you're meeting this criteria or not. Payroll companies are the ones that are most likely going to be stepping up and offering these types of services. If you're a community bank and you can kind of keep the part-timers part-time and the full-timers full-time, that would be our recommendation, because it becomes much more simple, much more manageable, but you will have to answer whether or not that's actually something that can be achieved in your bank.
Yeah, and just as an additional comment, for those of you that are outsourcing your payroll, start looking at your reports and start looking at reports that become available to you that identify employees based on the number of hours worked each month. That I think they're all going to start generating them. So start asking questions about where in your reporting system you can get that information, because you will need to have access to it. But I do think the payroll companies are going to be the primary source for most of this reporting stuff.
Yep.
Yeah. I'm going to touch briefly on this plan responsibility and what some people are doing, and I just want to give you a sense, because this is out in the marketplace. Some employers are trying to work around these taxes, these penalties, and there's a lot of different things that they're doing. One thing they're doing is they're offering what people in the marketplace are calling these skinny plans. A skinny plan is nothing other than a plan that actually offers preventive services only, because that is the only requirement of benefit-wise. That's the only thing that the PACA requires that you offer. So the employers that are doing that so that they get the minimum essential coverage. Remember, it's a real low base, and they're offering it to these people. And their deal is they're avoiding the big penalty that applies to every single full-time employee, and are willing to take the risk on having to pay the tack hammer penalty on the individual ones who actually go on the exchange, get a benefit, get it subsidized, and then it comes back to the employer. So that's one thing that's out there. I don't know that Advantage is ever going to do that for Advantage as a deal. It's something that's out there. It's really not the best way to contain your risk. For some employers, it's the only way.
Yeah. We do have employers that are on the skinny plan, but those are special industries that complying with the minimum or the sledgehammer penalty, and being able to offer those folks, full boat coverage. Banks have historically always done that. These are some employers and industries that they have not historically done that. And so if they did not have a skinny plan type of strategy, in some situations it puts them out of business.
Yeah, they're between a rock and a hard place.
Yeah.
Pay the penalty or
go out of business.
Or pay for the health care, and they can't do either one.
Yeah, both of them lead to
Yeah.
bankruptcy.
The other thing some employers are doing is they're starting to say, we're not going to cover spouses. Technically, PPACA says you have to cover dependents. The IRS says a spouse is not a dependent, therefore spouses are not required to be covered under the plan. I think AHP is not one that is going to say that we're going to exclude spouses. From an HR point of view, that's not always the easiest sell. The other thing is really working with the hours, cutting hours to be less than 30 hours, because you don't have to offer coverage to those people. There are some people that have done it. You've seen it in the news. I think it was Federal Express that cut a bunch of their people down to below 30 hours, so they don't fit the definition of a full-time employee. Again, that's for some employers, that's an easy thing to manage. For others, it's a very difficult thing. The last one is on here because it's kind of coming up as a thing where people are saying, well, we'll pay for the individual coverage. Interestingly enough, the concept was, I'll go ahead and take the sledgehammer penalty for you because I'm going to offer coverage to everybody, but I'll pay individual coverage. And you're going, okay, you think you got it, but the reality is that's a real problem. The IRS has come out and said that is going to be considered a health plan. It is definitely not a minimum value plan. It is not a minimum essential coverage. It doesn't fit very well. And what's going to happen is employers, at least the position that they've taken on right now, is they're saying, if that is what you're doing, then we're going to treat that as a health plan. And because you're not compliant, because it is not offering preventive services at full pay, no employee cost sharing, then it's subject to the real onerous penalties that are out there. And those are $100 per day per employee. So you're looking at $365,000 per employee per year. And then you start doing the math and you're going, that's not a very good alternative. We're working to develop and define things that will help you meet all of the requirements without going to these things that are so out there that really actually end up exposing you to penalties.
Yeah, this slide, we talked a little bit about it before we put it out there, and these are strategies. These are not necessarily strategies that we recommend. As Maria said, the fourth one, it's a definite no-no. We are hearing a lot of people talking about it, but we do have clarification from the IRS that will put you into the non-conforming plan arena. We've talked about the sledgehammer penalty and the tackhammer penalty. I think if you were doing that, paying for individual coverage, that's more of like the death sentence penalty. And just FYI, for those of you all that are in Oklahoma that are following the Hobby Lobby case, that's what Hobby Lobby is in. They're not paying the individual coverage. They're not doing that. But their plan, because it didn't offer the minimum essential coverage, is being deemed a non-conforming plan. And so I've heard it in the news media a bunch that, well, Hobby Lobby, if they don't comply, then they get a penalty of $100 per employee. And that's all they say. They're not saying it's $100 per employee per day every year that they don't offer minimum essential coverage. So,
and that's why it's very expensive to be a non-compliant plan.
Yeah.
Okay, 2015. The exchanges will again be open in 2015. Hopefully they work better than they did in 2014, which was not exactly a stellar rollout. But enrollment is not going to occur until after the elections in mid-November. Insurance companies are currently filing their plans with state insurance departments to get them approved, and it'll be interesting to see what happens. I think the delay to November is going to delay the actual cost information, so people don't really know how much more they're going to cost in 2015. I would anticipate that the cost is going to go up high. The automatic enrollment for those employers that are 200 or more full-time employees, you're required to automatically enroll them. That's been delayed until 2015. I have a feeling that may be delayed further, and I'm kind of keeping my eye on that, but it's hard to tell. From AHP point of view, there will be some plan, as Jay mentioned earlier, there are going to be some plan designs that need to be modified and consolidated so that we meet that federal out-of-pocket amount that we talked about, that $6,350 for this year. All of the changes will be effective January 1 of 2015. And they will be out, the designs and all of the changes, anything that is going to happen, you will be aware of them in advance of that date, because open enrollment that will occur in November through December of 2014, you will have advance notice on the plan offerings and what's different about them.
Right now, the plan designs are the changes that we are talking about. They have already been priced by the actuary. We actually have them we have them written down. We know what we're doing. However, what we're waiting on is the next trustees meeting, which is scheduled for the mid to late July. I think third week in July.
Yeah.
We will have all of the proposed changes with up to the minute recommendations on things maybe that other things that have changed. We're going to put that in a package with a bow on top and have the trustees vote on that. And as soon as they either approve or whatever they choose to do with that, if it is approved, these changes, then starting in August is when we will start rolling out this information and fielding questions from the banks on what will be offered on open enrollment.
Now, given everything we're talking about, the last element obviously is the reporting. And as you can tell by looking at the way that the determinations are made on monthly penalties as to whether you're offering coverage to all of your full-time employees and whether you're subject to the penalties because you didn't offer the right thing. And I mentioned to you that they're all done on a monthly basis. Well, the reporting is where all of this is kind of going to come into play.
This is the proof. We said at the very beginning we were going to talk about the penalties and how to comply. Right. And then we said, well, we're going to also show you how you prove that you're doing all these things. That's where we're at today. That's where we're at now.
And I think what we're going to do today is really give you just a very simple overview of what's happening. And the reason for that is the regulations have come out with what they say is going to be required. The IRS has yet to release the forms that are going to be used to do all of this reporting. So I'm missing a big element in terms of being able to give you more information. But I think we will probably do a webinar later in the year once we know what this information is going to require, so that we bring you back up to speed as to what you need to be doing at your end and to ensure that you got it right. Basically, from your end, there's two components of the disclosure that's going to have to be made. I call it a big black box, and it kind of worries me because there's a tremendous amount of information that's going to have to be reported that will be utilized by IRS, HHS, and DOL to all figure out what pieces come into play and who pays what. The two big components are the 6055, which is going to be that piece of paper that employees are going to receive, that they will use as their documentation to show that they did have coverage and are therefore not subject to the individual mandate. And employers are going to be required to tell the employees what coverage they had, whether they had it all year or which months they had it in, so that they have that documentation. When they file their tax returns, they will have that. Now, the mandate kicks in 2014 for individuals. The reporting doesn't kick in until 2015. So I guess we're going to be on a good faith reporting basis for 2014 tax returns. But by the end of 2015, all employers are going to be required to provide a statement to the employees. It's going to look, feel like, sort of like a W-2 report, in that it's going to be provided in the same time period as the W-2s are provided. It's going to be given to the employee by January 31 of the year, following the end of the year. It is calendar-based reporting. Regardless of what fiscal plan years a plan has, it's the employer that has to report on a calendar year basis, and it is going to be filed with the IRS February or March, depending on whether you're an electronic filer or not. But this is the documentation that the employee will retain in their files to demonstrate that they did have coverage and aren't subject to the mandate. As an employer, you're going to be required to provide this to every employee, whether they took the coverage or not. If you offered it to them and they chose not to take it, that will be disclosed on this. If they have dependents, you will report on their dependents that were offered the coverage and whether they took the coverage or not. And it is the employee's responsibility to share that information with their dependents. You will not be required to give that information to every dependent who's covered under your plan or every dependent who was offered coverage. And that's why I say it's similar to a W-2 kind of reporting, in that it goes to the employee. But I don't have the content of the notices yet. I don't know what the safe harbors are or which forms they're going to use. So keep in mind that this is going to come up, and this will be an area where, if the information is available to you through your payroll systems, this is a place where we're going to see some of this come into play in terms of you gathering the information to be able to provide it. The second part of it is the compliance side, where you as an employer are going to prove to the IRS, HHS, and DOL that you in fact did have minimum essential coverage, that you did offer it to all of your full-time employees, or if you didn't offer it to them, it's because they're not full-time employees, and that you had coverage on a month-by-month basis.
And that it was affordable.
And you have to tell them whether it's minimum value, and you disclose the lowest cost plan that you offered them to show affordability. All of this stuff is going to go into some semblance of a report that gets filed with the IRS, akin to what you do like with 1099 reportings and W-2 reporting, where you put all that information in boxes, except that this is going to be on all employees. And the concept is that the IRS, HHS, and DOL are going to gather all of this information from you as an employer and then put it into what I call the black box and match it up with the information of people that are on the exchanges and got subsidies or got premium payments on it, so that they can say Mary Sue got a premium subsidy. Mary Sue was employed by XYZ Bank. XYZ Bank says they didn't offer Mary coverage, and now they're going to come back to you and say you owe us the penalty. That's how it's going to work.
Or find out that Mary Sue went and got a subsidy on the exchange and come to find out that she was also offered
Affordable coverage
that was affordable, met all the standards, and so therefore was not eligible for the subsidy, and IRS going to want their money back from Mary Sue.
This is a big component of how this thing is going to work, because without the reporting, there is no way to determine who had coverage, who didn't have coverage, whether it met the standards or didn't meet the standards, whether it was affordable or wasn't affordable, whether they got a subsidy or shouldn't have gotten a subsidy. I mean, this is a big deal, but it is a huge amount of information that is going to be accumulated. I am anticipating that part of this reporting will be satisfied with some safe harbor kind of disclosures, where you don't have to give every single employee if you make certain certifications. Until the forms come out, I can't really tell you what it will be. But I know this is going to be a webinar in and of itself.
Without a doubt.
Because there is just so much pending.
We are, and I might just throw in, we are at the Kempton Group, Administrators of Advanced Health Plans. We are going to be working very diligently. My goal is, if it is possible for us to do the 60-55 reporting, we will attempt to do that. I mean, that's one of those things that if we have the capabilities of being able to do the 60-55, we're going to do that for the Advanced Health Plans membership. It's I think the chances of us having the information within our system is pretty good. 60-56, we do not, and we will not have all of the information that will be required for 60-56. Part of it will be at the health plan. In this situation, it will be at Advantage Health Plans, but part of it will be, for instance, at your payroll company. Yeah. And so it's going to be one of those deals where either Advantage is integrating information up to the payroll company, which we're actually working with ADP and Paycom right now to be able to exchange information back and forth. No guarantees. They don't really, without the forms, they don't really know what the threshold of compliance is either. But there is a concept on 60-56 that we may be able to provide data to certain payroll companies where they can put the two pieces together into one whole. But again, 60-55 and 60-56, we are on top of it as best as we can at this stage of the game, and it will probably be a future webinar in and of itself.
Stay tuned. A couple little bits and pieces just to kind of keep you abreast. We're still waiting on the Hobby Lobby decision to come up. The Supreme Court has heard the case. The argument, of course, is that Hobby Lobby provides prescription drug, it's really birth control. They provide birth control to their employees and dependents or spouses, but they do not offer a certain type of birth control. And the whole issue is as to whether or not they can exclude those items based on their religious merits, or if it is a violation of PPACA because they're offering a benefit that is not compliant with the preventive services. Everything has to be offered at 100%. And again, their exposure is, if they don't offer every preventive prescription birth control, then the IRS and HHS has taken the position that they're a non-compliant plan that is subject to the $100 per day per employee penalty, which is the $365,000 per employee penalty for them. It's a big deal. It's a big case. There's a lot of stuff going on in that area. There's a lot of confusion with, whether it's the religious liberty issue. And I think the Supreme Court probably will not render their decision until they're ready to walk out the door for their summer break. So I anticipate it'll be the very end of June before we hear. There's still a lot of problems with the states that did not offer the expanded Medicaid because of the fact that leaves a lot of people that are below the 100% poverty level that have no ability to get health coverage because they cannot log into the exchange, because the exchange only gives subsidies if you are between 100 and 400. That is going to create some issues. It's going to leave a lot of people still out there without access. And then the last case is the Pruitt case, which we've talked about. It's been ongoing for a long time. It is still at the state level. It has not moved up to any other level. It's whether or not these pay or play penalties that we've talked about can really be enforced against the employers in the state of Oklahoma, because in fact it is a federally run exchange, not a state-sponsored exchange. The statute says that the subsidy is available for individuals on a state-sponsored exchange. Pruitt says we're not a state-sponsored exchange. There have been similar cases. I know the District of Columbia had one very similar to it, and the Court of Appeals in the District of Columbia said it doesn't matter, state-sponsored, federally sponsored, they're really one and the same, which is kind of what the IRS is saying, they're really one and the same. It'll be interesting to see if Pruitt wins. These pay or play penalties in the state of Oklahoma would be dead for everybody. If he loses, then the IRS obviously is going to continue to enforce their collection mechanism. I don't have a timetable on it. It seems to be moving real slow, but it's up and coming. The only other point I want to just make to you is please keep in mind that this really is an area that is constantly changing. Stuff comes out literally on on every week. The regulations that are coming out are never 2-pagers. They're always 90 to 100 pages, and you have to read the fine print and their explanation, because that's really where they make their statements. They're issuing frequently asked questions, which I still don't understand what their authoritative value is, but they expand on what they say in regulations, and they're just pouring out. I've seen more in the last 60 days than I would have liked to have seen.
Sure.
And they're going to continue to come. And I think as this whole thing continues to evolve and people try to really put the whole thing in play, there will be more and more regulations coming out. So it is going to continue to change. And I think as we do the rest of the webinars this year, you'll hear us talk more and more of these new things that are expanded or clarified or modified or delayed. It is not set in concrete by anyone's stretch of anyone's imagination at this point.
Yeah. And we're kind of coming to the close. And the last thing I was going to mention is we also get a lot of calls from our banks and other employers about there's a lot of folks out there, consulting firms, all sorts of solution providers that are out providing free advice on ACA compliance. But if they have a product attached to their free advice, listen to them, but we also need to be savvy that in some situations they may be recommending a certain strategy that requires the use of their solution, their consultation, whatever. So please just be wary of that. We are approaching this we know that our bankers have plenty to do and budgets are tight, and so we are never going to recommend a vendor or anything out there unless we truly feel that it is in the best interest of the bank to be able to do what you all do, as opposed to just more regulatory compliance. So in other words, we are looking out for our bankers. That's what we're paid to do. So with that, we're going to open it up to questions. I do apologize. We're about 15 minutes late over on our time. So if anybody does have any questions, we'll wait here for just a minute or two and see if there's any questions. And if not, it's kind of the end of our presentation.
Jay, I did have one question from a bank that was emailed in.
Okay.
And they want to know if the tack hammer penalty has also been delayed or if it's still on track.
All of the pay or play penalties are delayed.
Okay.
For the large employers, the over 100 delayed until 2015. For the employers that are between 50 and 100 or 50 to 99, those go into play in 2016. And it's all of it, not just one piece of it, the whole thing.
Yep.
It's a good question.
It is a good question. All right. Looks like we do have a couple of questions. This one is 60-55 for employers under 50? That's a great question.
That's a really good question. I think the answer is no, but I'm not positive of it because the regulations are not 100% clear. Technically, the 60-55, 60-56 information applies with regard to the pay or play penalty. I know that they have delayed the actual tax provisions on the 50 to 99 employers for 2015, but they have not delayed the reporting for them. I think the answer is going to come down saying, no, you don't have to provide it if you're under 50 full-time and full-time equivalent. And the reason I hesitate on that is because I don't understand how they will be able to really determine whether someone is or isn't eligible for subsidies if they've got coverage somewhere else, unless everybody gets these reports.
But on the other hand, though, if an employee was to leave your employment, even though you're at a smaller group, 23 lives, if that employee was to leave and go somewhere else, they may need to be able to prove that they had coverage that met all the minimum requirements.
At some point.
So
the reporting on this, right now, I think there's so much that's unsaid until all of the forms come out. It's hard to put your handle on it. I can see this, the W-2s being amended to have a box that says, did you offer coverage to this employee regardless of who you are? And so I think even if we don't have the 60-55 for the 50 or under employers, I think they're going to require that information at some point, because there's no way they can administer this program when they realize that there are thousands and thousands and thousands of employers out there that are under the 50 employee mark. It's just not going to work unless they get everybody's information.
Okay. Well, we either did a really good job or everybody's asleep, but it's it's about 10 minutes till 11, so I think we're going to bring the presentation to an end. This is actually probably one of our largest attended webinars that we've had so far. We are going to be doing these, trying to do them on an as-needed basis, probably quarterly is going to be kind of our goal, as long as we have something to talk about, and I'm sure that we will. So with that being said, I'm going to go ahead and terminate the presentation. Hope you guys have a wonderful rest of your day, and thanks for your support.